All right, we are recording and participants are coming in.
All right, I see the numbers going up. Good morning, everybody. We are going to get started in just a moment. We'll give it just one more minute. All right, well, we are at 11:31. Good morning, everybody. I'm Peg O'Connell, the chair of Care for Carolina. I want to make a special shout out to hello Bertie County, hello Camden, hello Chowan, hello Currituck, hello Dare, hello Gates, hello Hertford, hello Hyde, hello Pasquotank, Perquimans, Tyrrell, and Washington counties. We thank you all so very much for joining us for this virtual forum on discussing the coverage gap and COVID in Northeastern North Carolina. This is the largest geographic forum that we've had. So we are delighted that you all would give us your time this morning. So as I said, I'm Peg O'Connell. I'm the chair of Care for Carolina. I want to give a shout out to Claire Mills from the Eastern AHEC who helped us pull this together. We are so fortunate to have co-sponsors who are actually on the ground in Northeastern North Carolina to tell us who are the best speakers and what the issues really are. And also, Kim Schwartz, I'd like to thank you for the co-sponsorship from Roanoke Chowan, the Community Health Center. So we really appreciate that.
You're welcome.
So it's very nice to see you. And Claire, we never got to see you, so I did see your face. I'm very pleased to get to meet you, at least virtually, so thank you. So what we're going to do this morning is we're going to have the speakers that you see on the agenda, and then we will open things up for questions at the end. There's a couple of ways that you can work this. While the presenters are presenting, all the other participants will be on mute. So if your phone rings or something, don't panic. But as we come into the discussion phase, you can either put questions in the chat box, which will be down at the bottom of your screen, or you can go to the participants icon, which is also at the bottom of your screen, and you'll click on that, and that will allow you to see all the participants, and then you can actually click the icon that will let you raise your hand if you'd like to speak. So there's a couple of ways, and I will remind you of that as we come in to the discussion phase. So without any further ado, and again, thank you to our co-sponsors, it's my pleasure to introduce to you Jason Gray. He is a senior fellow for research and policy at the North Carolina Rural Center. We have been doing these forums across the state, and Jason is what we are calling our numbers guy. He's a genius at evaluating pulling the numbers together, evaluating them, and then explaining them so that they make sense and you understand why they're important. So Jason, please tell us what's going on.
Thank you, Peg. Good morning, everyone. It's a great pleasure to be with you. So why is this important to the Rural Center? When the Rural Center developed its rural counts policy strategies in 2015, early 2016, we recognized then that we cannot have an economically healthy and an economically competitive rural economy unless we have healthy communities, healthy workers, and a healthy health delivery ecosystem in these communities. Just as with housing, with quality schools, this is a quality of life necessity for rural North Carolina. And the numbers that I'm going to be sharing with you all today reinforce that point. Next slide, Haley. Okay, so I want to put the put a little bit of context around my presentation is when we think about the closing the coverage gap, we have to look at it in terms of a chronic impact that it has on the state, and then the acute one, which we're trying to understand, which is a result of the COVID-19 pandemic. So we've got pretty good numbers on understanding like long-term impact, both in terms of the number of people who were in the gap and the economic impact of some form of Medicaid expansion. But we have far less certainty of the COVID-19 pandemic's short or long-term impact as it relates to Medicaid expansion. We'll share what I know. It's not as precise as what we know about the chronic impact. Next slide. So the numbers I'm going to share with you comes from a report that was commissioned by the Cone Healthcare Foundation and the KP Reynolds Foundation. And this report was carried out by economists and staff at the George Washington University in Washington, D.C., their School of Public Health. And the numbers I'm sharing is from an update done to this report, the Economic and Employment Benefits of Expanding Medicaid in North Carolina. Next slide, please. So it's important to understand that where did these numbers come from? So as Peg says, I deal with numbers a lot. I know how the sausage is made. Not all data has the exact same methodologies for production. So it's important to understand that these estimates I'm going to share come from an economic modeling program called the Regional Economic Models, Inc., REMI for short. REMI looks at the flow of revenue and outputs in local and regional economies. Think economic multiplier. So if a new plant comes to your community and it creates 100 jobs, those employees have a salary. They are spending that salary in the community, and the economic impact then trickles down through the rest of the community. Maybe another business gets to hire people. Another business has income revenue and tax revenue, and that multiplies through the community. So this modeling program, REMI, is one of two in common usage by economic developers and economic policy. In North Carolina, state government uses it, the Congressional Budget Office uses it, the White House Office of Economic Advisors uses it, and perhaps most importantly, not most importantly, but just important that the North Carolina Economic Development Partnership, the state's nonprofit economic development organization, also uses it regularly. So this is a commonly used form of analysis. Now, is it perfect? No. It is a modeling program of future impacts. So I tell people that an astrophysicist studying a star 20 light years away can tell you its chemical composition down to the second or third decimal point. We can't do that with any kind of socioeconomic modeling, but it's good, it's reliable, and it's commonly used. Next slide. Okay, so the numbers, the George Washington team generated statewide numbers, and then they generated estimates by county. And I'm going to share a couple county examples in a couple slides. So we took the data and we broke it out by the 3-county classification system that the Rural Center uses: rural counties, suburban regional cities counties, and urban counties. Almost all the counties in for this webinar are all rural. So I'm a rural guy, so I'm going to focus on rural numbers. So if Medicaid had been expanded in 2018, the job generation Carolina statewide would have been over 11,000 jobs. We're looking at a growth in gross county product, that is just general economic impact, of $1.9 billion, and a growth in county tax revenue by 2022 of $33.6 million. So this has a huge economic impact on rural North Carolina. There's no policy that the state could advocate or adopt that would likely have the economic impact of this. And even if these numbers are not totally accurate. Let's just say that they overstated by 25, 30%. So instead of $1.9 billion of economic impact, it might have 1.2 or 3. So I just say that again to highlight that even though we can't get precise estimates, we're pretty confident that the economic impact of this is significant. Next slide, please. So let's just look at some numbers for some counties. So Bertie, Dare, Hertford, Pasquotank. Bertie County estimated 29 jobs by 2022. Dare County, 547. My guess is Dare County has a hospital. So the job numbers tend to coalesce around larger medical facilities, hospitals. Hertford, 51, Pasquotank, 74. I suspect there's a hospital there in Pasquotank because you have Elizabeth City. Economic impact ranges from Bertie to 99 million, Dare County, and tax impacts from 93,000 in Bertie, 129,000 Dare, 150,000 Hertford. Hertford has a small hospital, Bond facility there, and $140,000 in Pasquotank. And this is important because rural counties, they're living on the margins in terms of tax revenues to be able to do work. Particularly now with the pandemic, counties all across the state, rural and urban, are facing real fiscal pressures because of the shutdowns of jobs, of restaurants and hotels, and how that then circulates in terms of local tax revenue. Next slide, please. So just real quickly, we broke this out by the Economic Development Partnership regions. And so for the Northeastern Partnership region, where we are, across the region, it's 1,259 jobs. Again, people traveling or traveling between counties to work. So I just wanted to point this out. And in a region where the economic challenges are deeply felt, this again has some regional impact. Next slide. For the Northeast region, $233 million of gross county product. Again, big impact. Next slide. And let's see, I'm reading my own math, $3.2 million in local tax revenue. So both locally and regionally, passing Medicaid, closing the gap, it benefits not only the 500,000 people or so who are without health insurance, but even if you have health insurance, you need to rely on your providers in your hospitals having the revenue to stay open so that we can keep the businesses we have, we can grow businesses in the future. And above all, how we have economic competitiveness. You know, this is a region that borders the state of Virginia. Virginia has now passed Medicaid. So the counties in this region that are on the borders, you are in competition with Virginia counties. I'm a Virginia native, so I understand this well. So we are at somewhat of an economic disadvantage now relative to Virginia because of this. Next slide. Okay, let's shift to our best understanding of what the pandemic impact has had. So these are numbers from January to July across the 80 rural counties. We had a decline of 94,000 people employed, a decline of 5%. I will highlight that the economic impact of the pandemic is flipped to what it was for the Great Recession, which hurt rural counties more, to the pandemic hitting urban counties harder because of the concentration of restaurants and hotels and retail in urban areas. Next slide. So another way to look at this is looking at unemployment insurance claims. Okay, so we look at total continuing claims that have been in the system for a while of 226,000 in August. The state estimates that 143,000 of them are COVID related. So that's 63% of all the unemployment insurance claims for the state. This is over May and June. And I imagine by now it's starting to get a little bit better still. Next slide. So taking that number, 140, how many of these folks are without health insurance? This is the difficult question to answer. And a lot of people across the country are trying to understand this. But frankly, they're all back of the envelope estimates. I'm sharing one here from the Commonwealth Fund, which is a health foundation, National Health Foundation. And their own estimates are is that 21% of the newly unemployed are, that is, they've lost their jobs or they've been furloughed, but maybe they have a significant other or a husband or a wife who's still has their job, their health insurance, or that they're already on the ACA. So it's very hard to estimate, but using this 21% estimate, we can roughly and reasonably estimate that 30,000 additional residents of North Carolina have lost their health insurance and who are now in this pool of people who need to be covered by some form of health insurance. Next slide. So just in closing, and I feel like I've kind of run on here, closing the coverage gap has substantial economic competitiveness advantages under the best of conditions. In light of the pandemic, closing the coverage gap would support a substantial number of North Carolina citizens who find themselves without coverage. So we have to understand that the decisions we make matter for those the least among us, the most vulnerable, the last and the least. But it matters for all of us who have health insurance and who live in rural places and want to continue to have access to health services. The pandemic is going to have a substantial effect on rural communities if we don't find a solution very, very quickly. So closing the coverage gap would certainly help. It's not going to fix everything, but it'll certainly help. Thank you. And I'll conclude with that. Back to you,
Thank
Katie.
you. Thank you very much. Our next speaker is Dr. Jessica Fuller Hines. She is a comprehensive rehabilitation in Spain, a pain specialist. And so she comes at this as a doctor, but also as a person who works with those who are using medicine to relieve pain, and also as a co-owner and president of a business. So Dr. Fuller Hines, would you take us through what's going on in your part of the state and what you're seeing on the ground there?
Absolutely. So we have a practice in Elizabeth City, North Carolina, as well as in Kitty Hawk. And we've been open about 13 years. So, you know, this is just my perspective about what has been happening in our community. Next slide, please. So in medicine, when you present a case, you're not allowed to use someone's name because of the Health Information Privacy Act. But typically we use initials. Because I live in such a small town, I've opted to not even use initials. So the woman in my case, I decided should be Wonder Woman, because she kind of is. She's a typical type of patient that I would see. She's about 44 years old. She doesn't have a bunch of other medical problems. And she's coming to see me about some low back pain that's radiating down her leg. So she's got sciatica. Her symptoms are interfering with work. So she works 2 jobs. She works in the Outer Banks restaurant. She also cleans cottages. And this is pretty typical of patients that I see. They're uninsured. These are not people who are, you know, supremely poor because they're not doing anything. They're trying to work and do what's right and provide for their family. She also has 2 kids. Her kids are aged 11 and 7. And so she is Wonder Woman. She's working 2 jobs. She's taking care of her children. She's providing for her family. And she has no health insurance. Next slide, please. So I'm going to ask Jason to forgive me if this is inaccurate. But from what I looked up, about 11% of our state is uninsured. This was prior to the pandemic. So Wonder Woman told me that she doesn't qualify for Medicaid because she makes too much money at her 2 jobs, but she doesn't make enough to be able to purchase health insurance on her own. And she was told that if she stopped working and she lowered her income, then she may qualify for Medicaid, but she has to provide for her children. And so, much like our furry friend that's in the picture, she's really stuck. And the only reason she shelled out her hard-earned money to come and see me is because now she's missing days of work, and she can't afford that. Next slide, please. So here's what I would recommend, and this is the standard of care for what she has. This is what's recommended by the AMA, by the American Academy of Pain Medicine, by I'm board certified by the American Academy of Physical Medicine Rehabilitation as well. So this is the recommendation, what she needs. Okay, so we will perform a thorough consult, including a history and an extensive physical examination. I would obtain x-rays and review them myself and also review them with her. Refer her for physical therapy for 4 to 6 weeks. And if she doesn't get better, then she needs an MRI for further evaluation and to discuss other treatment options like an epidural injection. And anywhere along this path, we could consider medications to help short-term with the pain. Typically, in the standard of care is not opiates. It is actually non-steroidal anti-inflammatory medicines, NSAIDs, like ibuprofen or Aleve, possibly a muscle relaxer, and something called a neuropathic agent, which is for nerve pain. That's what sciatica is. Next slide, please. So let's talk about how much all those things cost. She has no insurance. So the consult is $300. Her x-rays, the type that I need that would be useful, are going to run her about $500 between the x-rays themselves and the reading from the radiologist, another physician. The physical therapy is going to be at least $1,500 because she has to have an initial consult and then she has to have 4 to 6 weeks of treatment, like I indicated. If things don't go well, she's going to need an MRI. $1,800 is a very conservative estimate for a lumbar MRI, paying cash. She needs an epidural injection, maybe. That's going to be at least $300. And as I mentioned, those medications, so we would use like a neuropathic agent, a nerve pain medication, pregabalin, maybe a muscle relaxer, and the NSAIDs. That's going to total about $160, and that's only for 1 month, for 4 weeks. Now, here's the crux of the matter. So if you look at the next line, opioid medication, a price for hydrocodone for 30 days, taken 3 times a day, that's $30. Next slide, please. So this is what she gets. It's not the standard of care. We're not treating these people appropriately because she can't afford it. So she shelled out the $300 for a consult because she's missing work and she can't have that. She comes in, all these things are discussed, and we discuss all the medication. Well, the things that she really needs cost $160, but she already spent $300 for a consult, and she can't afford to miss any more work. So, she gets an opioid because it's cheaper. It's $30 a month versus $160 a month. And this is really the issue that we're dealing with. We're in the middle of an opioid crisis, and people can't afford to have access to the care that they actually need that would make a difference. The opioids are cheap, but we've made everything else expensive. And I mean, some of these things, they are expensive. They cost money to provide quality care, but if you don't have insurance, you can't afford it. And this lady can't miss any more work. Next slide, please. So what's going on with the opioid crisis now and before the pandemic? So there aren't a lot of articles out about it yet because we're still in it. And proper medical studies take a while to come out. But I did come across 2 that I'll share with you. So Wainwright and colleagues reported an increase in the detection of 4 tested substances in random samples that shouldn't have been there, for a total of 150,000 samples. So basically what we're talking about is people are on any type of controlled substance, or you're thinking about starting them on a controlled substance, you're going to get a urine sample and you're going to send it off to an outside lab. And so Wainwright and his colleagues looked at all those samples that went out and said, how many of those have things in them that are either illicit or something that wasn't prescribed that the patient shouldn't have been taking? and they saw an increase of 150,000 samples that were inconsistent, meaning they tested positive for either illicit substance or something not prescribed. And that was only in a 4-month period since COVID started. So an increase, they compared November to March 2020, and then did the middle of March to July. So 150,000 more samples that were inconsistent. Okolek and colleagues, this is a really interesting study. So they only looked at one emergency department in Virginia, but they compared how many non-fatal overdoses they had in that department for 4 months, from March to June of 2019, so pre-pandemic, to March to June of 2020. And they saw an over 100% increase in the number of non-fatal opioid overdoses during the pandemic. So this is a very scary thing. Next slide, please. So we have access issues. The one comment I'll make before I get into this is, so we've been watching the opioid crisis nationwide, year to year during this process. According to my professional organization, it seemed that we were actually bending the curve a little bit for the opioid crisis. So it's been going up and up and up and up. And we've taken all these measures as physicians, as communities, as people who care, as patients, to try and make things safer during this opioid crisis. And we were starting to bend the curve so that we were seeing less fatal overdoses, less non-fatal overdoses, less issues, with the crisis. Not saying it went away, but instead of it going up and up and up, we were at least starting to flatten the line. And now it appears that we're back on the curve headed up. So what's going on? We have these access issues. So primary care offices and specialty pain clinics have closed or reduced hours. There's actually a giant pain practice up in Virginia associated with a medical school where I've been getting tons of referrals, self-referrals from patients because they can't get in to see their doctor, because of COVID. They have, physicians have reduced hours or extra precautions we have to take. We can't see as many people on the schedule because we can't have as many people in the waiting room. And we have to, in my practice, we sterilize every exam room in between each patient. All those things take time. And so it means that we have less time, less number of appointments available each day. So this is part of the access issue. There are even less access to psych services. So part of a comprehensive pain program includes cognitive behavioral therapy, and that's a core essential part of treatment for people in pain. And we're having a hard time getting people in to see someone. We have limited access for treatment of opiate use disorders. And this is a huge thing to be able to combat the opioid crisis. And this is not going to see somebody a few times. This is an ongoing treatment. And we have people who have lost their jobs. As Jason said, they've lost their jobs because businesses have closed, they're working reduced hours. And so all of these things, and they've lost their insurance. And so they've lost access to healthcare. Next slide, please. So small business owners, and that's me in my little floral suite doing my thing. So small business owners, we don't have the bargaining power of large businesses. So I have 19 employees. I don't have the bargaining power as like a Target or, even a bank, like a Southern Bank or something of that nature. When I go to purchase health insurance for me and my employees, large businesses like a Walmart or a Target, they can go to Blue Cross Blue Shield of North Carolina and say, hey, we know your rate is $800, but we're not paying that. We're going to give you $400 because we have 1,000 people that need health insurance. And Blue Cross Blue Shield North Carolina will say, oh, okay. But when I go with my 19 people, they say, you're going to pay $800 per person. So we don't have that bargaining power. So I actually took a look at my healthcare expenditure last year for my 19 employees, and all of us are not on a health insurance plan. Everyone's offered it, but some people have it with their spouse or former military or something of that nature. But for the people who actually were on the plan, last year I spent $84,000 on health insurance. $84,000. It's on my taxes. It's $84,000. That is a ton of money. I mean, that's like more than most two people in North Carolina make. And a lot of small businesses don't have that large of a profit margin. I mean, believe me, I'm crying when I write out that check every month to pay the health insurance. But, a lot of businesses, that's enough to put them out of business. So a lot of them just can't afford to offer it. Next slide. So a couple take-home points. So there's a significant part of our local population that really needs health insurance. We're not treating, as Jason indicated, we're not treating the least of us the way that we should, but it also in the end is harming all of us by them not having health insurance. COVID-19 has further taxed all of these individuals because of the lost jobs, because of less hours worked, because of losing their coverage. The opioid crisis is already appearing to be worsened by the pandemic, which is a really scary thing. And, I gave you those studies that were only looking at a 4-month period. We have no idea what it looks like right now in October of 2020. A lot of small businesses also can't afford to absorb the cost of insuring all their employees. There will be businesses that won't function if they're required to pay for that. And so we just, as small business owners, all of us can't absorb those costs to be able to provide health insurance for each employee. So we really are at the point where we need to take steps to make a change. Next slide. And hopefully I didn't bore you all too much.
I have to tell you, that looks like Jason in that picture right there. And you just got a shout out on the chat. You didn't bore anybody. I have to say, Dr. Fuller-Hines, you are a rock star. That was just, we've had a lot of physicians talk us through this issue, but you really nailed all the perspectives. So thank you very much for your careful preparation. And how you got that picture of Jason, I don't know. But I think we'll use it in future seminars or something. It'll come back to haunt Jason, I'm sure. All right, thank you very, very much. Now we are going to hear from Kim Schwartz. She's the head of the Roanoke-Chowan Community Health Center, part of North Carolina's safety net. And the community health centers have been a great partner to Care for Carolina. And because they see the people who either don't have access to a private physician or because they're the only providers in town. So Kim, if you would tell us what you're seeing in the Roanoke-Chowan area as far as the coverage gap and what people are experiencing going through COVID.
Yes, thank you, Peg, so much. And thank you all for your attendance today. And I'm just overwhelmed by Dr. Fuller-Hines' presentation and the real story. So just an amen and shout out. Next slide, please. So I wonder if you would take a moment with me and write these numbers down. 10, 5, 1, 7. So take that moment, write down these numbers. 10, 5, 1, 7. And we'll talk about that in a minute. So yes, I have the privilege of being the CEO at Roanoke-Chowan Community Health Center, and we're in FQHC in Eastern North Carolina. Next slide. And that's a beautiful picture of the fields outside of my house. And so we have 5 clinical locations and as well as a school-based health center. So we serve Hertford, Northampton, Gates, Washington, Bertie, I missed one, 5 counties. There we go. So we have a big span of service areas. So from one end of our service area to the other would take us 2 hours to drive. So as the crow flies, we can move around. Next slide. So I want to tell you, this is the how we got started as a community health center. So back in the 60s, during the war on poverty, this is a picture of my colleagues in Mount Bayou, Mississippi. So this was the first FQHC. And so we're a little bit different than a health system or a doctor's office. We're a part of a movement, and that sets us apart. And I have to say, my board chair, Deborah Morrison, and our board is unique in that our board is predominantly and majority by statute have to be patients of the community health center and representative. But she says we're in the new movement in COVID. So these are some pictures of Mount Bayou, Mississippi, and how we got started. And Jack Geiger, who you see there touching the sweet baby's head, it said, medicine is how we got in the door. FQHCs look at what's going on in the communities and the impact in the community. So they got involved because there was no access to clean water. Testing is how we get in the door now with COVID. So that's an essential piece of the work that we do. Next slide. So we have lots of partners, and this is a picture of our Hosky site. And this is an angle that shows you East Carolina School of Dental Medicine. So we were the first community health center and first school of dental medicine to co-locate in the nation. And so we've gotten a lot of attention about this because it's so unique and incredible to have this in an area where there aren't just very many resources, and then to have this as a part of the Affordable Care Act. So we were both funded under state and federal fundings under HRSA, which is very exciting. So, but barely touches the need for oral health. And so we're expanding that care in our Bertie County area over the next 3 years with a federal grant as well too. Next slide. So this is what we look like. So we were founded in 2005. So we're just a little over 15 years old. And I say we act like teenagers sometimes as well too. And we have these locations of, we're actually closer to 20,000 patients now and over 180 employees. So we are in our counties, we in the top 5 to 10 employers, which is also something we're proud about. This is what our payer mix looks like, and it kind of reflects what rural America looks like. And we are fortunate enough to be providers of choice. So everybody comes here regardless of ability to pay. So this is our population mix and makeup. And you know these things about living in our area of the barriers to care, and transportation is a major one. We just, especially during the pandemic, even though we have some options, it's just not a real option for us. So we look just like most folks do with the health disparities, with cardiovascular disease, diabetes, and hypertension is those things that are attacking us. And I just found out yesterday, COVID is the 3rd largest killer in our country. So that's an interesting statistic that is current today that wouldn't even have been on our radar a year ago. Next slide. So we have a vast array of programs that we serve, from that expression in healthcare is cradle to grave, and we do about everything we can. Our team really does try to capture folks while they're here. And then of course we have telehealth, and that has been for us in COVID a major change. And we were fortunate enough, we've had a telehealth culture since 2006, and we quickly by the 1st of April converted all of our visits over to virtual and phone visits. So we are very fortunate. I'll show you a little bit more about that as well too. But we've got a whole array of services that we help across the board, just like most FQHCs do. Next slide. I show you this slide because I want you to understand the regulatory components and the stewardship required to be an FQHC, and to identify each community's individual needs. So what is unique to us in Hertford County or Bertie County or Washington County is a little different than what someone might have to deal with in Robeson County or Montgomery County. Or in a larger service area. And then the services that we have to provide have to be indicative to our area. So we are a designated agriculture outreach community health center. And so we literally, because we're agricultural based, have clinic out in the field. So during peak season, which we are in right now, we have clinics, and during COVID, we have this restriction because they don't want us there during this time, and it's very scary. But normally we have clinics out in the field 7 and 8 o'clock at night. And then we actually have one of our clinics open in Bertie County till 9 p.m. during this time, so that folks can actually come into the clinic after hours because they can't come during the work day. And then the management and finance, and I just mentioned the governance. We are governed by a board of directors, and I will tell you, I think I have the best board of directors in the world. They're just incredible and so engaged. And you talk about volunteering, they average between 5 and 10 hours a month of their volunteer time to our FQHC. So we have a lot of dynamics around that. I love that little S, the 19 requirements. So there we go. Next slide, please. So remember I said that number? Do you remember what we wrote that number down as?
10,517.
That totals this number right here. So that is the number of people that are uninsured in our 5 counties. 10,517 people do not have access to insurance and are standing outside of these services. Now in our FQHC, we have a sliding fee, but it only goes up by federal statute to 200% and of the poverty level. And so expanding coverage, the coverage gap, and we are leaving even more folks out this care because of the not having Medicaid expansion in our state. So remembering that in this area, that there are over 10,000 people who cannot access care or who do not have insurance because they cannot pay for it. So our next slide, please, is representative of the social determinants of health. We hear that all the time. My good friend Ben Money, who is our Deputy Secretary of Health and Human Services, says it really is the social generators of health. We recognize that in our area here, that we have real issues around racism and structural racism. And as you saw in our slide earlier, we're over 50% African American in our 5 counties. And so the challenges are that, we've had deeper historical issues around these social determinants, and the data even does not reflect equity-wise around those social determinants. For example, folks that come from the Black culture have historically not sought care. So when you talk about looking at strategic initiatives around data and say what their normal cost of care is, if you look over time, it's not going to reflect that because they don't seek care as often. And historically, that's been a huge challenge. And trust is a major, major factor. I've learned that more and more and more as I've learned and lived in this area for 15 years, what that means, that relationships move at the speed of trust. And that's a big issue for us. So the components of recognizing what our community needs. So you see there our Hartford Health Maintenance Alliance TRIP program that takes folks all over the place, whether they need to go to a job interview or a disability hearing or a doctor's appointment or to pick up groceries. We work with our local folks who have the mom and pop transports because we don't have that resource here, and they will take folks all over the counties that we serve, but we only have funding because there's no reimbursement for that. We only have funding for about 50 people to be in that program. So our Super SNAP is a great project. They're working with Food Line and partnership there that also connects additional support and help financially for food. And then our Farm to School to Healthcare program that integrates with our school systems here in Hertford County, and pop-up gardens, and works collectively for how we're here in this agriculture area and how to grow the foods, how to sell the foods, how to market the foods, how to use them in recipes, and how to have healthy eating. So very exciting. We've got lots of community partners in that. And that's our why. That's our big why as we go back to what we do. Next slide. So FQHCs, as I mentioned, we're a movement. We partner with the civil rights movement. That's our signature of who we are and what we are, being brave and courageous about talking about these difficult things. And so one of the components that we have is to recognize this as a community health center. So our care is discounted and nominal fee. So if you qualify at 100% of poverty, your total care, including labs and care for that day, no matter what it is $15. The same with our medication access. We have that as well too, that we bridge that as much as we possibly can for folks who don't have insurance. And I will tell you, our pharmacy team they perform miracles in getting that access to medication. We have extended hours of operation, so we're open 7 to 7 everywhere, somewhere, every day of the week except for Friday and Saturday and Sunday. We're open on Saturdays at our Hosky site, so that we can be available to folks that actually need that kind of care at different hours. And then now with virtual, we have even more access, which is very exciting. However, only about 40% of our folks don't have access to broadband in the rural area. And Jason and I have had lots of conversations around how we can do that. We, for our area, interpreter services are important for the Hispanic culture, and our agricultural worker health program that I mentioned to you is essential, that we are bridging with our outreach workers in the field. We have outreach workers even during this COVID. We're trying to provide that service, which is really challenging. And our organization has had a robust health equity committee, addressing some of these issues by our data, through our quality improvement programs, working with our partners, recognize our own implicit biases, and that just looking at our own selves and our own organization internally. A few years ago, we adopted policies for living wage and recognition of our own pathways to our careers internally and our investment in our community. One of the other signatures of community health centers is that we have to look like our communities in our employment as well too. So that is a dynamic that we are proud of and work very hard to accomplish. And then what's going on in our community right now is when you register as a patient, we ask, are you registered to vote? Because we help you right then and there, because your voice matters, and it's nonpartisan, and recognizing that as an FQHC that is funded by your tax dollars, we have that stewardship and responsibility to have representatives representing our community in regard to that. Next slide, please. So during COVID-19, we had to adapt quick, as I mentioned. So we couldn't bring folks into our in-house pharmacies. We have 2 of those. So we closed off part of our parking lot and turned into a drive-up in our pharmacy. That was an amazing thing, that we had to navigate that very rapidly. You see Dr. Charles Sawyer there leaning over and talking to one of his patients that's in the parking lot. And you see Misha there handing an iPad to a patient in the parking lot, because many of our folks don't have broadband and access, and so they were able to right then and there come to the parking lot. And although Dr. Sawyer also did not have a computer at home, so he worked out of our office here, 88 years old, by the way, and doing virtual. That's his total right now, is virtual, and how amazing that is. So you can teach an old dog new tricks, and he's a living portion of that. And then just what we look like during the peak of COVID. We do have folks coming. We are meeting our folks and registering in the parking lots now, so that we can keep safe. We have separate entrances for sick and respiratory visits, and we were the initial COVID testing sites in all of our 5 counties, and regardless of whether you are a patient or not, we did all testing, and we've had rapid tests. We were first agency in our regions to have rapid testing, so we've been doing rapid tests for about 4 months. And then there's our team. Aren't they beautiful? So the exhaustion of our team, having to do what they've had to do all day long, and the stress of their own fear of acquiring COVID, and the anxiety around that has been real challenging for all of us, and fostering our own resilience in this. These are my heroes. These are the people that I just will tell you that blow my mind, that this is what they do because they are called to do it, and they do it every day. And they would like to understand what that barrier is, that we are not able to serve these an additional 10,517 folks. That this is the data from last year, and we know that's even more since COVID, because of the job loss due to COVID and the essential workers not having access. So this next slide, this is, I think, the key in our area of recognizing one of the key factors of understanding why we need to expand access, because of prevention and early detection. So these are 2 of our staff members, and because we again, as our dear friend Jessica shared with us as well too, that the HIPAA. So this is Misha and Irina sharing about how important it is to get prevention and early detection. If you haven't had trust in the healthcare system and don't have trust that you can pay for it, and there's so many other barriers, why would you do prevention and early intervention and preventative care? So that is essential, that we are working on this culturally, socially, physically, logically and through our heart and our work that we need to do. I have to say that our team works so hard at this of establishing the relationship individually and one-on-one. You can put out all kinds of posters and you can do all kinds of social media marketing, but it really is about the one-to-one relationship and how we can do that. And it is heartbreaking to us when someone doesn't have insurance, and that's one of their barriers, and they're scared that they can't financially afford it. Next slide. This is how to reach me and how to check out our website and all the things that we're doing. And we're not unusual. All the FQHCs that I know are just like this, serving their communities and in the safety net. And we have all these great partners. And I shout out to AHEC. They've just been an incredible partner for us. Claire, as she knows, incredible work for us, and everyone that's been represented today. We're so grateful for the work that we share in together. And I really thank you for the opportunity and look forward to hearing more from the rest of our folks.
Thank you, Kim. That was excellent. And you gave us a real picture of what's going on in your communities. And it's heart-wrenching, very heart-wrenching. All right, so now we are going to hear from County Commissioner and Chairman of the County Commissioners in Bertie County, Ron Wesson. He is a retired vice president and gullible leader at Dun & Bradstreet. So not only does he care about people, but he can make the numbers work. And also, Ron is on the executive committee of the State Association of County Commissioners. So you folks up in Bertie County do things right. Ron, you want to talk about what your local government is seeing and how they're reacting to COVID, to the uninsured, to the coverage gap, and how that is impacting your ability to do your job and to run the county?
Great, thank you, Peg. It is my pleasure to speak briefly this afternoon on the economic and health-related factors influencing Northeast North Carolina as it relates to insurance coverage gap and the impact of the COVID-19 pandemic in this region. You know, when talking about Northeast North Carolina, there's a group of fairly contiguous counties north of Pitt County, southwest of the Outer Banks, that have very similar characteristics, and they, to a large degree, define Northeast North Carolina. At the heart of these counties is Bertie County, and that's Bertie, not Bertie. This is a county that I represent. And Bertie is as close to a microcosm of this area as one can find. So what I'm going to do this afternoon is to highlight Bertie, but at the same time, give you some visuals of the similarities shared between Northeast North Carolina counties in relation to health issues and the coronavirus. And I think it will be fairly easy to see the impact that closing the insurance gap in this region would have. Next slide, please, Hela. So here's the first visual that I'd like to share. You can see Bertie identified in the northeast quadrant on this map. This slide shows us the 10-year projected growth of counties around the state. Virtually all of the counties in the light gray cluster around Bertie represent 0 to negative anticipated growth. The numbers here are really very optimistic at best. Virtually all of the counties in this northeast sector, in the light gray again, are currently experiencing negative growth. Next slide. Average income per capita. I hope you can still identify Bertie again here in the Northeast. The Northeast quadrant, eliminating the Outer Banks, which is a separate being altogether, is one of the lowest income areas of the state. Bertie currently stands at $20,430 average income per capita. Next slide. So this slide looks at children living in poverty. The visual here is a little skewed because Bertie, Hyde, and Hertford are only 1 percentage point off of the highest scaled area here at 32%. But 21.8% of all households in Bertie are below the poverty level. Next slide. Persons average 65 and older. And we all know the impact of health-related issues on senior populations, including COVID-19. The Northeast, as you can see here, and the far west portions of the state have not only the largest percentage of seniors over 65, but are also the fastest growing areas in the state. Bertie currently stands at 23.6% of citizens over 65. Next slide. One of the areas that I spend a great deal of my time working on is food insecurity. At 22% of households in Bertie so defined, and 24.8% of households on SNAP, so many lives here are negatively impacted by food insecurity. In the third largest county in the state, 740 square miles that we have one grocery store, and many factors in Bertie, as well as the surrounding counties, have numerous areas defined formally as food deserts. Next slide. Now, this is a related slide. Here you see the visual of the monthly recipients of food and nutrition services. Bertie, in the red, stands at 24%. And food insecurity is very real in this sector. I know my wife and I, with the help from an awful lot of volunteers for the last 5 years, have been running a backpack program that feeds 210 elementary school kids in Bertie each weekend during the school year. And I can tell you that the numbers have grown each and every year that we've been doing this. Next slide. So I'm sure you're kind of getting the hang of these slides by now. This slide shows persons without a computing device. Bertie in the green, dark green, stands at 28%, with some counties in the Northeast running as high as 38% of the population without a computing device. Next slide. And this relates to the previous slide, looking at broadband internet subscription rates. Again, in the light in the Northeast sector ranges in the low to middle 50% range. Communication is a vital part of any, communication is a vital part of any, in rural communities. Can you imagine distance learning, telehealth, or the difficulty attracting businesses with only 50% access to broadband? Next slide. Unemployment rate. I bet the number on this slide will confuse many of you on this call. These percentages represent the average of unemployment rates for the months of April through June of this year. Can you believe that Bertie and many of the counties in the Northeast had the lowest unemployment rates in the state during this period? And actually, Bertie led the state in the last 3 months with the lowest unemployment. But if we only look back to any pre-COVID-19 quarter of the year, these same counties in the Northeast would have ranked in the highest unemployment rate areas. So the question is why? And what you find is that this area of the state has one of the highest number of, quote, essential jobs populations in the state. Businesses like chicken processing plants, state prisons, or nursing homes, etc. And they have very few of the businesses that were required to close, like restaurants, gyms, bars, and etc. per capita. Next slide. So this slide really is just a quick summary of what I showed in the previous slides, but I want to give a little attention to two of the factors here. The first is race, and it's an important factor in the Northeast. 62% of Bertie County is Black/African American. In fact, it is the largest minority percentage majority county in the state. But also you might want to know that there are 8 minority majority counties in North Carolina, and 6 of those 8 are in the Northeast. And you look at those with 40% or more minority population, there are 14 counties, and 11 of those 14 are in the Northeast. We know race has a lot to do with pre-existing conditions like hypertension, diabetes, heart disease, obesity, and they have a significant impact as well around COVID-19. The other on the right-hand side is employment. I spoke a little bit about the kinds of jobs we have in these areas. Purdue Farms, 3,200 employees in our county. State prison facilities, nursing homes. We have 3, and most of the counties have several nursing homes, hospitals, schools, etc. And these are all high profile COVID-19 impact employment. So that makes a real difference. Next slide. I wanted to give you just a little look at the COVID results or counts, if you will, in Berkeley County through October the 9th. We've had 644 cases, 27 active, 14 deaths, 338 per 10,000. So that's kind of right in the middle of the pack. We have counties in there like Edgecombe that are well over 1,300, Hertford County that's up in the 700 or 800, even a small county like Chowan, over 600 total cases. Below this, in the bottom part of this, is the funds that we have received from the North Carolina Coronavirus Relief Fund. $926,000 has been awarded to us. And here's how we spent those dollars. About $599,000 of those dollars went to public health expenses, things like medical and protective supplies for police, social workers, child protective services, disinfecting public areas, even quarantining individuals, etc. And about $255,000 is going to payroll expenses for public safety, public health care, human services, etc. And that last number, 71,566, we've awarded grants to municipalities in Berkeley for the same kinds of funds that they've put out in order to deal with the COVID-19 virus. Next slide, please. So uninsured persons, Berkeley County stands at 13%, and the region somewhere between 11 and 14%. And I saved this slide to the end, near the end, because I wanted you to see the visual that the Northeast mirrors most of the state in regards to the percentage of uninsured. But let's take a closer look at the actual numbers of what closing this uninsured gap would mean to counties like Berkeley. Next slide, please. And I think Jason has shown you this already. We took our data from the same places, so I won't cover it in detail, but the 2 important things to see: the number of new medical enrollees. That's significant. 1,119 in 2019, 1,219 in 2023, and the net economic impact, which is the gross county product, $5 million in 23, $2 million in 21. These funds would have a significant impact. Our local government, for instance, currently subsidizes our local Vidant Hospital for indigent care to the tune of more than $100,000 each year. And we own that hospital, so we lease it back to Vidant. But these kinds of funds would have a significant impact. Next slide, please. So, my last slide. In closing, let me say that I truly love working in local government, the government closest to the people. And I could probably name 30 unique things that we've done in Berkeley since the onset of COVID to address health issues in the county. For instance, as I said, we've continued to appropriate funds to our local hospital to deal with indigent care. We own that facility, and we built that facility to attract a hospital that could bring care close to our citizens. We now have, as you've seen, 3 actual healthcare centers located in Berkeley County. And we also own and operate our EMS division. We were the first county in Northeast North Carolina to provide a licensed paramedic on every 911 call. And I think you're seeing more of that spread around counties, especially in the Northeast, where counties themselves are participating in that kind of business. You can still have other for-profit businesses. And we are currently training our paramedics to make what we call wellness checks on chronically ill citizens in our county. So these are just a few. But the most important thing that a local government can do is to identify and build consensus, and then to advocate for the needs and concerns of its citizens. Let me give you just one example. 2 years ago, the person who won election to represent the First House District here in the Northeast was a Republican, and he opposed Medicaid expansion. 2 years later, this same person is running for re-election, and he and his Democratic opponent both have announced their full support of Medicaid expansion, and both support coverage of pre-existing conditions. Advocacy is important, and it can make a real difference. Thank you, and I look forward to our discussions.
Oh, Ron, you know, every one of you all just is knocking me out. You're so passionate and so on point and understand so much of what's going on in your community. And you'll be getting calls because the presentations you're making today need to be heard by the policymakers that you're talking about. So, wow, thank you. Thank you very, very much. Now it's my pleasure to introduce Erica Palmer-Smith. Erica is the director of Care for Carolina, and she and Haley are the real brains behind the operation. Erica's going to talk with us about some policy opportunities, which Commissioner Wesson alluded to, and what we see possibly going forward. So, Erica?
Absolutely. Thank you, Peg. And thank you to all of the speakers. It is quite an honor to speak after all of you. Haley, next slide, please. So what I'd like to do is to start off by making sure that we all know that we do have a tremendous opportunity right now. We have an opportunity in North Carolina to expand quality, affordable coverage to nearly 750,000 North Carolinians. We have an opportunity to ensure that all of our frontline workers through this pandemic have access to timely testing and treatment of COVID-19. We have an opportunity to help stabilize the healthcare system by reducing the amount of uncompensated care costs. And we have an opportunity to provide a lifeline to struggling families. And we can do all of this with 90% of the funding coming from the federal government from tax dollars that we already pay. There have been multiple pieces of proposed legislation put forward. Last year, House Bill 655, North Carolina Healthcare for Working Families, would have closed the coverage gap by bringing down those 90% of federal funds. And it was a bipartisan bill that ended up passing out of the House Health Committee with a vote of 25-6. House leadership promised a vote on the floor. We were never given that vote on the floor. There have been other pieces of legislation. House Bill 1040 was healthcare for working North Carolinians would expand Medicaid in North Carolina. That bill was not given a hearing in committee. House Bill 1103, access to affordable health coverage for all, would provide subsidies for folks living in the coverage gap. That bill has not seen any movement either. What we know is that the legislature right now, tomorrow, could act to close the health insurance coverage gap. And given what our speakers have so eloquently presented, the need for that could not be any greater. And so we know that right now is the time that the legislature needs to act. Next slide, please. We also know that North Carolina voters agree. Next slide, please. Care for Carolina funded a poll at the end of August looking at voter support for closing the health insurance coverage gap and found that 75%, 3 out of 4 North Carolina voters support closing the coverage gap, and only 16% oppose. Next slide, please. This support holds up across every demographic. And again, this is not a partisan issue. 64% of Republicans in North Carolina support closing the gap, along with 83% of Democrats and 76% of unaffiliated voters. When you look at ideologies from liberal all the way to very conservative, we have 60% or better support. When you look across every demographic, age, race, gender, even down to what region of the state folks live in, we continue to see widespread strong support for closing the gap. Next slide, please. When we looked in some specific districts in the state, one of those districts we looked at encompasses many of the counties that we're meeting in today, including Senate District 1. Next slide, please. And in each of these key districts, we found overwhelming voter support. In Senate District 1, which encompasses, again, much of northeastern North Carolina, 64% of voters in Senate District 1 support closing the health insurance coverage gap. One other thing that I want to mention, we know that COVID-19 has had a big role in determining how folks looked at this crisis and the support for closing the gap. 78% of voters believe that the impacts of COVID will be long lasting, and we've seen increases in the amount of support when looking at Medicaid expansion specifically, going from 72% to 77% of voters statewide. But what I also want to end on is when going back to how critical it is that we move now, a third, 1 out of every 30 voters in North Carolina is concerned about their own family's access to healthcare in this pandemic. So we, as our presenters have demonstrated, people right now are hurting, and this isn't something that we need to continue to push off. This is something that we need to do right now. We know that there is widespread voter support. We've also seen many states recently enact legislation or through voter referendum close their health insurance coverage gaps. Now, North Carolina does not have the option to close the gap through a voter referendum, but North Carolina does have the option to vote to make sure that we close the health insurance coverage gap. Right now is the time to talk to your legislators. Right now is the time to vote for your legislators. And so it could not be any more critical that we act on this issue today and in the coming weeks ahead. Thank you.
Thank you, Erica. All of you have been very, very well spoken, and I thank each of you. I thank you, Jason, for always bringing us the big numbers, and Dr. Fuller-Hines, thank you. That was one of the most comprehensive and understandable presentations that we have had, so thank you. And Kim, your passion is absolutely contagious. And Ron, Commissioner Wesson, you knocked me out. You really did. And I'm coming back to you to ask you to help us some more with some of your other more hard-headed county commissioners. Not in Bertie County, of course. They're all sweethearts. So now what we'd like to do is we can open up the mechanism for some questions from those of you in attendance. If you have questions, mostly the things that have been in the chat box so far have been comments and shout outs. But if you have questions, you can put them in the chat box or go to the bottom of your screen, click on participants, and you will be able to actually raise your hand, and we would open the microphone so you can speak. So while you're doing that, you know, I want to take the privilege of the chair in working up the invitation list for this. I called Edenton Town Hall to get email addresses, and I got to speak to Anne Marie Knighton, who I have decided, and I think she will agree, that we may be very, very distant cousins. And so I'm proud to say that I have a cousin in Eastern North Carolina. And as you know, in North Carolina, that's close enough. So Anne Marie, I saw your name. I'm glad you're with us. So the I'll tell you what, if it's all right, I will start with Jason. You know, North Carolina has a very short window of unemployment benefits. One of the cases we've been making in your numbers is the number of people who are now unemployed, possibly having lost their insurance, having very little income. Will the numbers that you present precipitously fall off as people reach the end of their North Carolina insurance benefits?
Well, that's a good question. So, I mean, we've seen considerable improvement since May of people rehiring or bringing furloughed workers back. But as probably most of you all know, the end of July, the federal supplements for the pandemic run insurance ended. So what we're trying to sort out now is how many of the unemployment hit we took in the winter and spring, how much of that is going to turn into permanent unemployed. So the typical unemployment and number given, okay, so right now I think the unemployment rate in North Carolina is 7.9%. So it's come down, but that's a very technical definition that does not include discouraged workers. There's another U.S. Department of Labor estimate called the U6 unemployment rate, which takes into account those who are working part-time but who would like to be full-time, to those who have just dropped out of the labor force. And that number is much higher. It's around 12.8%. So we are in a very precarious situation now. And as most of you all know, there's debate in Congress and between the White House around another stimulus package. The Federal Reserve has made it very clear that the economy needs another stimulus package, and it's unclear whether we're going to get anything before the end of the year. We now run the risk of many of the temporary unemployed becoming permanent. I think particularly in the food sector and the restaurant sector, restaurants have been able to make do by having outdoor seating with colder weather coming on. And then the factor of, what's going to happen in colder weather with the pandemic. Does it flare back up? Epidemiologists I've heard and public health folks I've heard suggest that may yet happen. So there's a lot of unknowns. So I guess I'm sounding like an economist and I'm hedging everything I say, but we certainly need another federal stimulus package, or temp unemployment is going to become permanent unemployment. And that's a big worry for me.
Very good. Thank you, Jason. So we have a couple of questions in the chat box. I will start with the one from Annabeth Brown from Husky. She writes, there are so many advantages to expansion. What is the reason for not expanding? What are you hearing? Eric, I'll toss this to you first. What is the reason that you hear from opponents about not doing this and having not done this for the last 10 years?
Sure. Well, I'll give you the two reasons that we hear most commonly, but I will also explain to you why, in my view, and I think based on the facts, those arguments don't really hold water. So the first, we hear things based on the cost, and we hear things based on who we're covering. So when it comes to cost, we are consistently hearing this false argument that the 90% of federal funding could go away. That argument ignores what is actually written in the legislation. In the Affordable Care Act, it states that the federal government will fund 90% in perpetuity. This is not a number that the administration could just choose to change. It's not something that can be done easily. This is something that would require a change to federal law. It would require a change to the Affordable Care Act. That is not something that we see being very likely or happening very likely. What we do hear consistently is compared to, for example, the Children's Health Insurance Program funding. Well, the funding that was decreased recently was was bringing back down a temporary increase. And again, this is a different program. There's different legislation that dictates this program. In order for the 90% to go away, the Affordable Care Act would have to be changed by Congress with legislation signed by a president. The second argument that we hear is this idea that folks who would gain coverage are somehow undeserving. We hear this phrase, childless, able-bodied adults. Well, I'd like to tell you a little bit more about who's in the gap, and I think that many of you already know this, but first of all, the folks in the gap are predominantly working. I think Dr. Fuller-Hines gave a very clear, real example of some of the folks living in the gap. 63% of those folks living in the gap are working. We also know that many of the industries that are most likely to be in the gap are those frontline worker positions. So nursing home aides, childcare workers, grocery clerks. These are the folks who are most likely to be working. I think, again, Dr. Fuller-Hines gave an excellent example. Restaurant employees and housekeeping staff are two of the most likely industries to not have sound health insurance available through their employers and be stuck in the coverage gap. And I think that we see a lot of those positions, not just everywhere, but especially in Northeastern North Carolina, where we have more tourism in some of the communities. We also know that these aren't necessarily childless adults. About a quarter of the folks living in the coverage gap are parents. To qualify for Medicaid in North Carolina, a parent has to make 42% or less of the federal poverty line. For a family of two, that is about $7,200. If you have a single mom with one child and she's working 40 hours a week, 52 weeks a year, making minimum wage at the job or jobs that she does, she is making double that. But she is not making nearly enough to get help in the private insurance marketplace. That is a prime example of someone, just like, again, Dr. Fuller-Hines, you couldn't have given me a better example. Someone working two jobs with two children who's falling in the coverage gap because she's making too much to qualify for Medicaid and not enough to get help in the marketplace. So again, we are not talking about people who choose not to work. We are talking about hardworking North Carolinians, many of them providing for families. And this is something that, you know, again, we may hear this stereotype, but it's not the reality that we see.
Very good. Thank you, Erica. Any of the other panelists would like to make a comment on that?
Yes, Peg, I would. This is Ron West. I think Erica did a great job of giving us the facts about why it really doesn't make sense not to do this. But having worked a lot with legislators, I think it's important to understand that, you know, just like in wearing a mask, this is not a political statement, whether you wear a mask or don't wear a mask. But in the legislature, you know, one body is trying to hold their folks in line and putting an awful lot of pressure on them, even if they know personally that it would impact their citizens in where they live and represent in a positive way. And we've seen that in my first House district, where we elected a person who was absolutely against it. But we were able to advocate, to show him, have citizens show him how this would impact their lives. And so, you know, if you want to really represent us, you got to know what the majority of your constituents want and need. So you make that case. And we were fortunate in this case to be able to do that.
Very good. Well, I will ask you to work on the other number one in your area, which would be your state senator.
That might be a little bit harder.
Well, I was going to say, from your mouth to God's ear. All right. Any other panelists have a comment on that?
I better pass on that one.
Yeah, I was going to say, I think Commissioner Weston said it perfectly. So we have another question, and this is from LaDonna. LaDonna, how are you? LaDonna worked with us early on, and I'm glad to see you're still hanging in on this issue. We're going to get it done. This is a question for Kim. If the Supreme Court was successful in repealing the Affordable Care Act, how, please don't tempt fate, how would that affect funding for the FQHCs and the ECU School of Dental Medicine? Kim, can you respond a little bit on that?
Sure. Hey, LaDonna. Yes, I saw the question, so I had a few minutes to think about it. And again, God forbid, and actually hearing a little bit about what they would have to break things out. The mandate is what the issue is. I think the compelling components of the Affordable Care Act have I think will stand the test of time, and the pre-existing conditions and the dynamics around the access, I think those are there. And as Erica explained as well too, the matching with the Medicaid dollars, it is scary to think about that. And the issue really is that we don't have Medicaid expansion to pick up those folks in the gap. So if they do fall through, and that does happen, that is a very even more scary proposition, because that would even leave more people in that gap. As an FQHCs, we are funded not through the Affordable Care Act. We're funded under the 330 federal statute. Now, we are always under threat because they only fund us 2 years at a time. So those of you that the small business that we talked about that earlier, we only have a 2 year at a time. An infrastructure. And so we talk about that all the time about needing the permanent funding for FQHCs. I mean, just think about it, the 41 FQHCs in the state went away and we lost our funding, what that would mean. And there already has been reductions due to COVID, and that it's just a challenge. So that would be very devastating, not having that support of the ACA for that. Again, would add more numbers to the gap.
Thank you. Anybody else have a thought about that? I will have a question for Dr. Fuller-Hines. You are so close to Virginia, Dr. Fuller-Hines. When you talk to your colleagues before COVID struck, because Virginia's had Medicaid expansion for about 2 years now, when you talk to them, can you give us a sense of, or maybe you don't talk to them because they're mean.
No,
And,
I do.
and they're all, we got Medicaid expansion, we don't care about you. Has that changed things for the work that they do and how they're able to see their patients?
It has. And beyond just the Medicaid expansion, Virginia Medicaid has also made some changes to the things that they will allow for treatment in terms of pain. Specifically. So that's mostly what I do. For instance, in North Carolina, when you have any type of condition, pain or otherwise, when you go to physical therapy, they will only see you for 3 treatments. That's it. That includes the initial visit. Virginia has expanded their availability so that patients actually can get the standard of care for physical therapy. They're covering a lot of those other medications besides opioids that I mentioned. So they've done some other things with their Medicaid besides just expanding the access. They've made the access more meaningful as well. So it makes an easier environment for people to get really the help that they need for pain and all sorts of other chronic diseases. And I just wanted to touch, I'm not going to beat a dead horse too much, but it really, I think it's a huge mistake for people to think that most of the people that we're talking about are lazy or unworthy. It's really what I see all day long are the people who they're really working, like they're hustling, they're working, a couple jobs, sometimes 3 jobs, really to make ends meet, and they're just not getting the help that they need for their overall health. And it doesn't just affect them, it affects all of us, because when those people are in an accident or they have some type of emergency and they go to the emergency room, we're all paying anyway. So we might as well cover them so that it's not, as expensive to us.
Very good. Well, the old line, pay me now or pay me later.
Exactly. Exactly.
So we are very close to the end of our time. Thank you all. I will say this, an election is coming. Some of you may have already voted. This is not a partisan organization. We do not engage in electioneering, but as you make your choices, if this is an important issue, then find out where your policymaker stands and make the case that if they want your vote, they need to think about what they can do about this. Erica will be sending out follow-up information with your county data sheets, also some action steps. If any of you would like to write letters to the editor or want to learn how to be in contact with legislators, we are very happy to help you. You know how to get a hold of Erica or me. So we are going to make this happen. We've got our eye on 2021. where I think even some of those hard hearts, Commissioner Weston, are starting. I don't know whether they're melting out of concern or they're melting out of fear for the fact that they may not be there. But regardless, we are making progress. And LaDonna, thank you for coming to our very first prayer breakfast. I am glad to see that you're still around. Erica, do you have any last word?
No, the only thing is I hope everyone saw Anna Bess's note in the chat box. You will receive the follow-up email, like Peg said, from me actually just momentarily. But please consider taking one of the actions in there. We are doing our best to make sure this issue is loud and taken notice of, and having organizations and local businesses and faith organizations join us really helps pound that drum. And so we really hope that you'll consider adding your name.
And in closing, our colleague Meg Malloy, who is working with our friends at NC Child, she is organizing our business and civic leader outreach. So when you go to that website, you can add your name as a business or a civic leader or a faith leader and say that you are in support. You can sign a resolution. And for those of you who are in local government and would like specific resolutions or templates, we are happy to get those to you. So thank you all for your time and attendance. And again, speakers, you really knocked me out. And we've done a lot of these. So don't tell the people in Greensboro I said this, but this is the best one. So thank you all very much. Jason, Dr. Fuller Hines, Commissioner Wesson, Kim, Erica, thank you very much. I think we are adjourned.
Thank you all.
Yeah.
Bye-bye.
Bye-bye.